Bismillahirrahmanirrahim. I'm Dr. Nadia, Awais, Associate Professor Gynae. Today we are going to discuss fibroid uterus. Uterine fibroids are the benign tumor of uterine smooth muscle and are called as leiomyomas. They commonly present in 20 to 30% of the women of reproductive age. They are more common in obese and in nulliparous women. Grossly, the fibroid is a nodular outgrowth which causes enlargement of uterus and distortion of its normal structure. They can be oval or round in shape, firm in consistency, and has characteristics white whorl appearance on cut section. Microscopically, they are composed of smooth muscle cells arranged in whorl pattern mixed with variable amount of connective tissues. They are classified in relation to the uterus in major three groups. They can lie within the body of the uterus, cervical fibroids, or intraligamentary fibroids. Now, when they are within the body of the uterus, they can be submucosal, subserosal, or intramural. Subserosal fibroids are those who project into the uterus onto the peritoneal cavity, and sometimes they can be pedunculated. They cause least symptoms. Submucosal fibroids are those that project into the uterine cavity and they cause maximum symptoms like irregular vaginal bleeding, heavy menstrual cycles, and infertility. Intramural fibroids are those that lie within the uterine wall and they are usually multiple. Cervical fibroid, they arises from the cervix, the supravaginal portion, and are usually single. Intraligamentary fibroid are those which are smooth muscle fiber within the broad ligament, that is round ligament or ovarian ligament. Fibroids you can see in the picture according to their location. The one which is lying into the cavity is the pedunculated fibroids, and the other which lie in the wall, they are multiple in number, are the intramural fibroids. Now the symptoms of fibroid are different. Mostly they are asymptomatic. They can cause menorrhagia as heavy menstrual periods, iron deficiency, anemia, abdominopelvic mass, and sometimes due to the presence of that mass, one feels or go to the consultant for the assessment of heavy lower abdomen. Pressure symptoms like urinary frequency, pelvic tumor awareness, difficult initiating micturition, pain, infertility, and irregular vaginal bleeding are also related to the presence of fibroid depending upon their location, and mostly they are due to the submucosal fibroids. Now, fibroid, they are estrogen-dependent tumors that grow slowly because they are more common in the patients who are premenopausal, who are on OCPs or taking estrogen-dependent low-dose hormone replacement therapy, and will regress with the menopause. The malignant potential is less than 0.5%, and complications which are related to the fibroid are the degeneration. They can be hyaline degeneration, fatty degeneration, red degeneration, torsion of pedunculated fibroid. Subserosal fibroid can cause pain. Parasitic fibroid are again when the fibroid is attached to the uterus and it is subserosal and gets its blood supply from some other organ of the body, sometimes even from the momentum. They are called as parasitic fibroid. Calcification, infection can occur in the parasitic or the pedunculated fibroids. Hemorrhage, it can occur if the patient is having a fibroid and she is going to have cesarean section or myomectomy. Now, investigations which are commonest, the gold standard investigation is the ultrasound. On ultrasound, one can see a heterogeneous echo, lucency, size and location of the fibroid can be seen. Saline hysterography is useful for pedunculated submucosal fibroid. MRI is considered to be better than CT scan imaging techniques to see the exact number and location of the fibroid. Especially it is helpful in treatment of the patient who are having infertility. Stereoscopy is a therapeutic and diagnostic technique for the fibroid diagnosis. Laparoscopy again is an endoscopic technique by which you can diagnose fibroid, while you are going to do laparoscopy for some other procedure like it is a laparoscopy diagnostic for infertility and you see a fibroid which previously you haven't missed on the ultrasound. Investigation of the submucous fibroid areas. In this picture you can see the round circle, the fibroid is between the arrows. Now submucosal fibroid can be seen in the hysteroscopic image, the whitish area. The management depend upon the age of the patient, her fertility concern, associated complications. Conservative management is placed for small asymptomatic fibroid, fibroid in pregnancy or puerperium, or observation every 6 months. Medical management is also available for preoperative till the time of surgery, patient near the menopause or newly married with minimal symptom, red degeneration with pregnancy. Treatment of the symptomatic fibroid includes the correction of anemia, hemostasis cure, analgesia, antispasmodics, antiprostaglandins, and anti-estrogens like low dose of progesterone, tamoxifen, diazole. GnRH analog is the drug which can be used for the large size fibroid to decrease their size because they causes the size reduction 50% after 3 months regular use of GnRH analogs because it decreases the vascularity. GnRH analogs are expensive, and after 3 months of the use you have to use low dose HRT to avoid the postmenopausal symptoms. The surgical management is myomectomy, which is conserved for the young woman, incomplete family, patient's concern, and fertility concerns. Myomectomy can be done abdominal, vaginal, endoscopic, by hysteroscopy, laparoscopic route. Uterine anti-embolization is a newly available radiological technique, and MRI-guided specific lesion of the fibroid can be even treated, which is a radiological technique. Hysterectomy is the final resort for the patient whose age is more than 40, has completed their family, they have multiple fibroids, there are recurrence of fibroid, or there is a suspicion of malignancy, or during the myomectomy if the major damage occurred to the uterus, and for hemostasis cure you finally ended up with the hysterectomy. Like for your understanding, if a patient is having myomectomy and she is having more than 3 fibroids, there are 10% chances she would have ended up with hysterectomy. Now, fibroid have association with the infertility. It is said that 3% of infertility is due to fibroid, and most infertility specialists will recommend removal of any fibroid with more than 50% of its surface in the uterine cavity. The results of removal of a single fibroid can be dramatic. There is evidence that removal of intramural fibroid more than 5 cm diameter will enhance fertility. Fibroid during the pregnancy, 80% will remain unchanged in their size, rarely rapid growth and red degeneration, increased risk of bleeding and threatened preterm delivery in patients who are having fibroids. Fibroid in the lower segment can interfere with vaginal birth failure. Myomectomy at time of cesarean section is not wise because it causes 30% requirement of emergency hysterectomy. Thank you.